taking the time to join us today. Laura was feeling a little under the weather today, so I'm really pleased on behalf of the ICS Science Office and our Health Equity Working Group to welcome you to our session today, the latest installment in our Health Equity and Focus speaker series. We're really excited and fortunate to have two excellent presenters today sharing the details of their mixed method study that use both ICS data and qualitative interviews to understand the pregnancy health outcomes and care experiences of Ontarians with disabilities. And first up, I will introduce Dr. Hilary Brown. Welcome, Hilary. Hilary is an ICS Adjunct Scientist and Assistant Professor at the University of Toronto in the Department of Health and Society and at the Dalla Lana School of Public Health. She's cross-appointed to the Department of Psychiatry and is an Adjunct Scientist at Women's College Hospital. Hilary also holds a Canada Research Chair in Disability and Reproductive Health. Hilary's research program examines maternal and child health across the life course, with a particular focus on populations with disabilities and chronic illness, health equity, and social determinants of health. Thank you for joining us today, Hilary. I'll also welcome Laurie Proulx. Laurie is a peer researcher and managing director of the Canadian Arthritis Patient Alliance. Laurie has lived with juvenile rheumatoid arthritis disability since she was 14. And her lived experiences led her to become involved with the Canadian Arthritis Patient Alliance. She currently works part-time for the Alliance as managing director and also works as a consultant for researchers, healthcare organizations, patient organizations, and charities. Her consultancy focuses on patient and community engagement, knowledge translation, health and social policy analysis, and workplace inclusion for disabled people. So welcome to you both. Thank you for joining us today and your willingness to share the results of this interesting study with us. But before I turn it over to our speakers today, just a reminder to please remain on mute during the presentation. Feel free to unmute and turn on your camera for any questions, and Elise will be managing the questions. You can also add questions into the chat box or raise the hand function. We will also have a Mentimeter set up for questions as well, and Elise will manage that. So once again, welcome today. Thank you for joining us. And I'm pleased to now pass it over to our presenters today. Thanks again, and over to you, Hilary.
Wonderful, thank you. And actually, Laurie's going to kick it off, so I'll pass it to Laurie.
Thank you.
Yeah, sounds good. Yes, and Elise, would you mind just sharing our presentation? And that would be great. Go. Great. All right. Let me just adjust a few things on my end too. All right. Well, thank you so much. My name is Laurie Proulx, and thanks so much for inviting both me and Hilary here today to talk about our work about the inclusion of people with disabilities in research, more specifically lessons we've learned from a study on disability and pregnancy. Just go to the next slide. You can see our Twitter handles there too. Feel free to tweet about this if you're on Twitter. Happy for you to share any of the content there. These are just acknowledgements in terms of our funding for this work. So we thank very much the National Institutes of Health and the CIHR for their support. I'd also like to do a land acknowledgement, which is on the next slide, Elise. I know I'll just be sort of blasting through these first few, so apologize for the quick pace, but I would just like to do a land acknowledgement in terms of where I sit today in that I live, play, and work on the unceded territory of the Anishinaabe Algonquin Nation, which is known today as Ottawa. I'm from Eastern Ontario, so I actually grew up close to the Mohawk community in Cornwall, or what's known as Cornwall. So, and I just think this is something important to reflect on as we think of the intersectionality too of disability and other identities, and just think if we can all take a moment to reflect in terms of the land that, or the territory that we live, play, and work on. So, and then in terms of the outline for today, so moving on to the next slide, really we're going to give a little bit of the context, a bit of history too about the experiences of people with disabilities in Canada and internationally. We'll specifically talk about the research that we did, the research process, some of the research results, as well as the impact, and share with you some lessons learned, and that'll be from both my perspective as well as Hilary's perspective. So my perspective will be maybe a little different because I live with a disability for most of my life, and in terms of what that meant in terms of my inclusion as a peer researcher on this work. So on that note, you can just carry on to slide 6, really, Elise, and I'll give you a little bit of a break here since I'll hold here for a bit. So yeah, just to give a little bit of background about some of the policy measures out there for people with disabilities. And I think it's really important to reference here the UN Convention on the Rights of Persons with Disabilities, which was established in 2006. To promote, protect, and ensure the full and equal enjoyment of human rights and fundamental freedoms by people with disabilities, and to promote respect for their inherent dignity. And in terms of this convention, or I'll call it the CRPD, sort of going forward, they talk about persons with disabilities having long-term physical, mental, intellectual, or sensory impairments, which in interaction with various barriers hinder their full and effective participation in society on an equal basis with others. And I mention that definition only because I think it's important to recognize that we're talking about in terms of the policy recognition here of both sort of a medical model of disability as well as a social model. So the medical model really sees disability as like impairments or things to be cured or fixed, for example, while the social model recognizes that people with disabilities exist in a society and they experience barriers by virtue of just interacting with the world, or obstacles. So anyways, that's just important to sort of preface as you're looking and thinking about disability and how it fits into society more broadly. The CRPD, though, more specifically protects the reproductive and parenting rights of disabled people. I also like to mention the CRPD Canada is a signatory. It was ratified. It took a bit of time, but it was officially recognized, I think, in 2010. But that being said, so it does protect the reproductive and parenting rights of disabled people to decide freely and responsibly on the number and spacing of children, the right to guardianship, access to family planning, etc. It's estimated that about 12% of reproductive age women have a disability, leading to calls by the WHO for better reproductive health for women with disabilities. I found it interesting to kind of look at the date because indeed I had my first child in 2006, which is only 2 years after this broad statement was made. And you'll see, I think, as we talk about the results of our work, that the disability communities continue to experience disparities in reproductive healthcare settings. So next slide, and here we're going to show you a short trailer of a documentary, a Canadian documentary film called Unloved, Heronia's Forgotten Children, which is directed by Barry Cohen and was released just last year. You can watch it. If you do a Google search, should be able to watch the whole thing. I think it's about 30 to 40 minutes. And it really documents the history of child abuse at Ontario's Huronia Regional Centre facility for developmentally disabled children, based in part on the story of Barry Cohen of her own 2 older brothers, Alfred and Louis, who died at the institution. And really, we're just, seeing awareness of what happened at Huronia from 1945 to 2009, which is actually a pretty recent history, right? As a class action lawsuit revealed the dehumanization that was going on throughout that time. And I'd like to note that may be difficult to watch. I notice many people have their cameras off anyways, but just if you need to take a moment, take a breath after watching this, I just wanted to ensure that you were all aware and not surprised, because it's not easy to watch, even for myself after watching it several times. So briefly, let Elise play this trailer.
Remember Mom and Dad telling me that I was going to go to the hospital for people that are retarded. Mom let go of my hand and the nurse with the cap took me in. I was so afraid.
The first name was the Aurelia Lunatic Asylum for Chronic Patients.
From the very beginning, Huronia was notoriously known for its terrible conditions.
It became the Aurelia Asylum for Idiots.
The sadism that occurred at Huronia was absolutely the norm.
Went there in isolation. They broke my teeth, they broke my legs.
We had a bunch of psychopaths taking care of us.
I was terrified.
They drugged you up. They drugged you up. Who would believe me? Who would believe any of us?
It was a deeply loveless place. There are spaces that tell people that they are unloved and unlovable at every turn.
2 half-brothers. Both go to the same place at 3 years. None of us kids knew Alfie or Lewis. No one spoke of them.
Look at that. So that's what he looked like.
He came in perfectly healthy.
Our brother Alfie was found dead in his bed. He was 23.
They murdered him, in my opinion. You don't let a kid die. You're supposed to take care of them.
All those years from 1971 to 2009, the government had been told to close the place. It's a mess.
And in 1963, they passed standards North America-wide. Huronia completely failed to comply with these standards.
The court approved a $35 million settlement in a class action suit.
It was never about the money.
The only thing that pisses me off, I want to be able to say, this is what you guys did to me.
Many of them regret they never went to court to tell their story.
So we need to learn from that.
We felt that it was important to have survivors tell their story through this monument.
If you don't talk about your story, nobody will listen.
Thank you for playing that, Elise. Yeah, and I think really moving forward, I think we just need to learn from that. In the words of the woman there, I think it's just something to be cognizant of and aware of as we do research with and by people with disabilities. So on that note, I will carry on to just continue to explain. And I mean, the legacy of the treatment of sort of people with disabilities continues to this day, right? With, these sorts of facilities closing and attitudes slowly but surely changing, we still see disparities experienced by people with disabilities across all aspects of life, from childhood, education, employment, housing, income, access to support services or to health services and that. Although this, you can reference the report here from NHS Scotland, just in Canada, just to bring some more Canadian data to the fold here, people with disabilities are less likely to be employed than those without, at a rate of 59% versus 80%. And however, 2 in 5 of people who are not employed and not in school had the potential to work. And it's important to note that people with disabilities too are identified as one of the groups at greater risk of living in poverty under Canada's poverty reduction strategy and generally have lower incomes. I mean, you can just go look at some of the statistics data to kind of get a more comprehensive view as to what the supporting data is saying here. And there's a need to access healthcare services, assistive devices and these accessibility features that are built into their home. But on that note, I mean, I'll sort of switch gears a little and talk a bit about my own personal long and winding road to parenthood. And as was noted in the intro by Mike, I mean, I was diagnosed with juvenile rheumatoid arthritis, as it was known at the time, when I was 14 years old in 1991. And so really, I've had a lifetime of experience of living with a disability, right? From having difficulties participating in school and university, in relationships and choosing a career. And then of course, having children was just another extension of some of those experiences and some of those impacts. So, pregnancy and family planning were more complicated for me. My first child, Claire, you'll see here on my journey in 2007, was born. And I soon figured out during that time that actually it was a bit of a disappointment, I'll be honest, right? That a lot of the medications that I had come to rely upon for much of my life to that point weren't necessarily compatible with pregnancy or breastfeeding. So I remember being sent for counseling and having, and at least I did have access to those things, but it was just so stressful to realize that a lot of these things were going to be much, much more difficult for me. With my daughter, with that first pregnancy, I lived in a lot of pain, I'd say, during the first trimester because I wasn't able to take the medications, and we just didn't have the evidence to support their use. It's actually quite a difficult decision to make in terms of do you take and do you not? One that involved my partner as well. And it was just really in contrast to how we see sort of pregnancy and parenting as being this time of joy and bringing a new life into the world. But, I feel like those times were more sort of, tempered with stress and sort of sadness about what I could and couldn't do. I also received advice that I would flare after the birth, so my condition would flare, and this was well known at the time. So this also had sort of longer term impacts on breastfeeding, right? And again, I could end up having to go back on the medications, or my option was to live in pain. And let me tell you, I've talked to lots of women with inflammatory arthritis, and they've made the decision too to not go back on their meds and to breastfeed their child or chest feed their child. And I think it's just hard, right? When you look around at your peers and what other parents are doing, as well as sort of the added messaging that breast is best, right? But yet, it's just not something that's quite attainable. And I mean, albeit I'm very thankful for like the support I received from my family doctor at the time, from my rheumatologist, who made me realize that, or helped me realize that, I had to make these difficult trade-offs, but I think they just acknowledged where I was and how I felt. You'll notice a bit of an age gap between my kids. So I experienced multiple pregnancy losses as well between 2007 and 2012. And I could probably have a whole other talk just about some of my not so great experiences there. But my second pregnancy in 2012 to my son, Charlie, it didn't go as well. I was not in as good of a state. My health, I had to go on, corticosteroids, and they didn't quite do all the work. I also was being seen by many different healthcare professionals because I was a high-risk pregnancy, and I really felt the lack of coordinated care, as I see as a big contributing factor, as well as my medications, to the near-death experience I had. I mean, my son and I almost both lost our lives. And I was in and out of hospital during my third trimester. Suddenly went into crisis after I checked myself into the hospital. I'd like to note it was through my own efforts that I reported back, and they admitted me for the third and final time that time. And I went into crisis, had a seizure, and then I woke up in intensive care. I had an emergency C-section. My son was all right, but he was not breathing when he was born and was admitted to the neonatal intensive care. I still had difficulties breathing, and ended up going for a second emergency surgery the day after he was born, for a tracheostomy, which is something I lived with for 2 months. So I had like, a newborn, a tracheostomy, recovering from ICU. So suffice to say, it was an incredibly challenging time for myself, my husband, and my then 5-year-old daughter, as well as my parents who took on more. And I'm just so fortunate, really, to have had the support I did. But nonetheless, these are these experiences that I bring as a peer researcher to the work with Hilary. So with that, I will pass it over to her.
Thanks so much, Laurie. So we'll just go to the next slide. Thank you. I think both the history around disability and healthcare that Laurie presented, as well as her own story, just shows how important this topic is and how important a really careful approach to our research is as well. So just to kind of set up our research study, there had been some prior research on disability and pregnancy, mostly from the United States and the United Kingdom, broadly showing that people with disabilities experience disparities in health outcomes related to pregnancy, and also barriers accessing healthcare in both pregnancy and postpartum. Most of these studies have been fairly small, limited to clinical samples or small surveys, and many of them focused on one disability group. So, for example, people with physical disabilities only or developmental disabilities only. And so when we started this research in 2017, there was a real gap in knowledge and really showed the need for research, particularly from a Canadian context, in order to inform healthcare provider training as well as clinical care. Next slide, please. So that leads us to the overall aim of our study. So our goal was to work with people with disabilities, service providers, and decision makers to look at the pregnancy-related health outcomes and healthcare experiences of women with physical, sensory, and intellectual and developmental disabilities in Ontario. So as was alluded to in our title, this was a multi-method study, and part of the study used ICS data to look at pregnancy-related health outcomes in people with and without disabilities. And the other component of the study was a qualitative study to understand the pregnancy-related experiences of this group, both from the perspectives of people with disabilities, as well as from the perspectives of service providers. And so what we'd really like to do today is to present not only the findings of these two parts of the studies, but also how we engaged community in both components and kind of the challenges that we experienced throughout, the lessons we learned, and the things that we think we did well and would do again as well. But I'd also really like to, as all of you are affiliated with ICS in some ways, reflect on what these findings show in terms of what ICS data can show us and where we do need extra information, and where other research approaches can really help to complement and support and sometimes even fill in the blanks of what administrative data are not able to give us. So with that in mind, we're now going to talk about our research process and its impact. So next slide. So I'll first maybe briefly introduce you to our study team. So the faculty on the project included myself and Yona Lunsky as the co-principal investigator, Astrid, who you all know, along with Joel Ray and Simone Vagode, who are also ICS scientists. And then we had two colleagues from the US, Susan Haberkamp and Susan Parrish, who are experts in disability policy. Laurie, you see here today, served as a peer researcher on our team, and we'll talk a little bit about what that role was, along with Kate Welsh, who's another individual with lived experience of disability who also served as a peer researcher. We had a number of graduate students and postdocs who were involved at different phases on both the quantitative and qualitative side of the study. And then importantly, we had quite a large advisory committee of about 30 members, mostly from disability advocacy organizations, as well as parents with lived experience of disability. And we also had representatives from the Ministry of Health and the Ministry of Children, Community and Social Services, as well as a couple of obstetric clinics that offer accessible pregnancy care. So it was a really neat opportunity to kind of bring together people from multiple sectors. So thinking about, disability and social services coming together with healthcare and people from the community as well. And we'll highlight what this group was really able to offer the research process as we go through this presentation. So next slide, please. So just to kind of give you an overview of how we integrated our teams from kind of the academic and community components, one of the most important, I think, first steps that we went through was to create a terms of reference document to really guide our work together. And this was a really practical document that outlined the objectives of the project, the roles of the different members of the project team, expectations around communication, including respectful communication, knowing that we were all coming from very different walks of life with very different backgrounds. And just to highlight briefly, this even included really simple things like avoiding jargon. I think as researchers, we get so caught up in, the technical terminology that we use, the clinicians that we work with use a lot of medical terminology, but we really wanted to make sure that the ways that we communicated with each other during meetings were just accessible to everybody from an understanding point of view. And so that was included in our terms of reference document as well. And then we had some other practical components around expectations for authorship and how we would acknowledge the advisory committee as a group when individuals weren't included as authors on specific items. Our advisory committee met several times per year. This sort of fluctuated throughout the life cycle of the project. We met pretty frequently in the first year when we were sort of determining our study objectives and creating some of the data collection materials for the qualitative component of the study. And then throughout the study, we met as well. Often this was in terms of reviewing preliminary findings. So for example, every time we had a paper that we were writing up for publication, our first step before submitting the paper was to present the findings to the advisory committee to make sure that everybody was on board with the framing of the findings. And you'll see some examples as we go through of where the committee provided some really key input that sort of changed how we interpreted results. And then finally at the end, and I guess we're still sort of in the end phase, really doing some work around knowledge sharing and sort of figuring out the products that would come out of the project. As I mentioned, Laurie and Kate as peer researchers were core members of the study team. So we met with them more frequently. They co-led data collection with Leslie Terzoff, who was the postdoc involved in the qualitative component of the study. And they also co-led data analysis and were involved in all of the papers and presentations for that component. And they've also been really key in terms of helping to lead our knowledge translation activities. Kate in particular is very artistic and has created some neat products for us, like whiteboard videos and that sort of thing that we've been able to share with people. So it really was key to have these groups involved in planning, implementing, and sharing our results. All right, next slide, please. So one thing I want to highlight, and this has been sort of a work in progress in terms of my learning, and I think our learning as a study team, but it was quite difficult throughout to figure out the ways in which the advisory committee could have real and meaningful input on the ICS side of things, because we are limited to a certain type of data, a certain portfolio of variables that we have available to us. Really what we have is what we have. And so there's less flexibility in terms of what questions we can ask. And so that's been a real challenge, I think, throughout in terms of figuring out how to really meaningfully take on the opinions of the advisory committee when we can't always address the types of questions they want us to ask. So often for the population-based study, input was really more around interpretation and framing of the findings, as opposed to determining the real direction of the study questions. On the other hand, the qualitative study, I think, really took on more of a community-based participatory research approach, where there was decision-making power among the advisory committee in terms of what the data collection tools look like, and in terms of Laurie and Kate's, equal participation as data collectors and, being co-leading analysis and data interpretation as well. And so for these components, we were able to include them as co-authors on the papers and presentations that have resulted from the work. So with that, I'll go into some of the specifics of the study. So next slide. So just a very brief overview of our population-based study. This was a study, of course, using health administrative data from ICS for people with a birth over about a 17-year period. And of course, as you all know, we were able to link mom and baby data through the birth hospitalization record. And one of the challenges with this type of work around disability specifically is that we are reliant on a medical model of disability, which uses diagnostic codes to identify disability based on, our kind of typical algorithms of 2 or more physician visits or 1 or more hospital admissions or ED visits for a diagnosis related to a physical, sensory, or intellectual or developmental disability anytime prior to the conception. So if you can just click next, that'd be great. So for this, really, the advisory committee engagement was around input on interpretation. I remember we had a lot of conversations at the beginning about the limitations of only being able to measure disability using a medical model, as opposed to having self-reported information on disability. And that was a really kind of key limitation that we've tried to be very clear about, since there's nothing we can do about it with the data that we have at the moment, but at least to recognize that we're not capturing people without a diagnosis, and we're not capturing people who don't have access to healthcare for their diagnosis. So next slide, please. So one of our major findings was regarding pregnancy rates in people with disabilities. We looked at pregnancy rates over about a 15-year period. As you can see here, pregnancy rates in the different disability groups for physical and sensory disabilities are actually not all that different from the group without a disability, which is the dark black line at the top. We did see lower pregnancy rates in people with intellectual and developmental disabilities and multiple disabilities. But overall, one of our key messages from this project has been that in total, 1 in 8 pregnancies in the province are to people with a disability. And so clearly obstetric care needs to consider the needs of people with disabilities in its delivery. Next slide, please. Okay, and I'll get you to click next again. Thank you. So we also looked at preconception health in people with disabilities, focusing on indicators that we had available in the 2 years prior to pregnancy. Not surprisingly, given what we know about health inequities more broadly in the population, we did see inequities related to neighborhood income quintile among people with disabilities, higher rates of comorbidities related to both physical and mental health, greater likelihood of using medications that could cause congenital anomalies, and a greater history of assault anytime prior to a pregnancy. And one of the main messages that we heard from our advisory committee around this component is just the real limited information that we have in our health administrative data around social context. So if we're only able to measure income at a neighborhood level, for example, you can even consider Toronto as a great example of this, where there's so much variability even within a neighborhood. We know that people's circumstances aren't necessarily reflected in the population level data that we have. And that's been an important point of reflection in all of our papers, to really acknowledge that we aren't able to measure the social and structural factors that often have a real kind of impact on people's lives. Next slide, please. And next again, thank you. So one of my master's students, Fariha, did this great analysis looking at prenatal care adequacy in people with disabilities across the different disability groups using the Kotelchuk Prenatal Care Adequacy Index that we often use with ICS data, which is really able to capture access to prenatal care on the basis of the timing and number of prenatal care visits. And we didn't see very many differences between the groups, except for the group with intellectual and developmental disabilities, which was more likely to receive inadequate or no prenatal care compared to their peers. And one of the sort of learning points I want to highlight through the next couple of slides, including this one, is the real important input that our advisory committee and peer researchers had around language. So for example, the first time that we presented this to our advisory committee, we had used the language of the timing of entering prenatal care, because that's what's often used in the literature. But our advisory committee really pointed out to us that that puts the onus on the individual, and it sort of makes it seem as if it was a conscious decision to, quote, enter, prenatal care later. And so we had a lot of conversations on what would be appropriate and landed on the language of receipt of prenatal care. Because it shows that it's the system offering something to an individual, and often it is systemic and structural barriers that are the reason why people may receive prenatal care later than their peers. And next slide. And so similarly for perinatal outcomes, and I won't get into all the kind of modeling that we did on this, but just from kind of an absolute kind of descriptive sense, we looked at a number of indicators of both maternal and newborn health. And you can see in the bar graph here, the disability groups are in the colored bars and the group without disabilities in the black bar. And we did see important disparities among people with disabilities in terms of higher rates of these outcomes. And again, an important learning opportunity with our advisory committee was around language. So as is typical in the literature, we had started off with some language around adverse perinatal outcomes. And we heard that the term adverse is quite stigmatizing and medicalizing. And so we changed our language to more neutral language around just perinatal outcomes or even perinatal complications. And another important learning piece with our advisory committee as well was when we write up our discussion sections of our papers, as epidemiologists, we're trained to focus on risk and trained to focus on when things go wrong. So for example, when looking at severe maternal morbidity, we could say, oh, wow, almost 4% of people with intellectual disabilities experience severe maternal morbidity. That's a major headline because it's twice as often as in people without disabilities. But actually also 96% of people did not experience severe maternal morbidity. And so one of the kind of interpretation pieces that we've gotten into the habit of doing is reminding the reader in our discussion sections of our papers that the majority of these pregnancies go just fine. And yes, there are disparities that we need to acknowledge and address, but we also don't want to over-medicalize people's experiences. So that's been a really important component as well. And so with that, I'll hand it over to Laurie to talk about the qualitative study and the really rich data that piece added to our project.
Thank you so much. So yes, I'll briefly speak to that. And as Hilary had mentioned, the advisory committee, had noted that, the data only speaks a certain amount, right? And so this qualitative piece really provides the context for trying to understand the data that Hilary just presented. So, as she noted, we recruited people with physical, sensory, and intellectual and developmental disabilities living in Ontario who had given birth in the last 5 years. There was also a second sort of outreach and contact with healthcare and social service providers and decision makers. And so this is where myself, Leslie, and Kate did the outreach to the organization. So reaching out ourselves, working through the advisory committee members who also in some cases had, I think even myself, I referred people that I knew who met the criteria, lived in Ontario. So it's through those sort of connections, with organizations or individuals that we were able to recruit as many participants as we did. So we screened the potential participants, we developed the interview guide as well, and did the outreach with the advisory committee on that, and then actually conducted the interviews. So for example, and then in terms of looking at the results, for example, Kate and Leslie did a lot of the coding for the data. I did more of the interpretation of the results and looking at things and reflecting on or reading through the transcripts and that sort of thing for the final sort of analysis. And I think we also worked with trainees, which I think is a good opportunity for them as well. You know, as Hilary mentioned, there were a number of sort of individuals doing their practicums and these sorts of things. And I just think it's a good opportunity for them to learn early in their, you know, academic journey or careers to involve community members and work with them that way. So on to the next slide to where we can highlight, where I'll highlight a bit some of the key themes of this analysis. So people noted a number of unmet accommodation needs where they couldn't even access some of the basic aspects of pregnancy care. Where, for example, here we talk about accessing the clinic and getting up or being able to use the examining room, for example. Others didn't have access to, you know, sign language interpretation where their family members were relied upon to provide that, which creates, again, an extra burden on the family member. And, you know, of interest, I remember in looking in some of the interviews was even someone with visual difficulties couldn't even see the pregnancy test result because they couldn't actually, there was no accessible element to the test that we can get at Shoppers Drug Mart or wherever, right? People also noted a lack of coordinated care. There's actually someone with RA noted here in terms of, you know, providers speaking to each other or accessing perhaps the more specialized services sort of needed for people with disabilities. And it places a lot of additional stress on people to work with these different care providers and try to ensure that they're talking to each other. I can very much relate to all of this in terms of my own personal experiences. Because I would flare periodically during my pregnancies, I did need to access the obstetrics unit by wheelchair at times, but it was kind of like left to me to figure out like a support person to come with me to, enable me to actually get to my appointment because I couldn't walk. So anyways, just to say that I can very much relate to these findings. In terms of the continued themes that we heard, it really is, and it's funny, like when we were doing some of the analysis, I think it was Kate that mentioned, like, let's just call it ableism, right? And so ableism, for those who may not be familiar with the term, really is a set of beliefs that guide the way we think, and they can be embedded in our culture and our institutional practices that sort of ascribes like a negative value to people with disabilities, while sort of deeming able-bodied people as normal and therefore superior to their disabled counterparts. And I think the quote here really reflects that clearly. They're saying, you're not capable of being a parent, right? And honestly, again, I heard very similar things or very cryptic things from my providers even before I became pregnant, like you'll need a strong partner. And I was like, what is that supposed to mean? Like, I'm still, you don't think I'm able to be a parent, and it doesn't inspire confidence in yourself either, right? When you're surrounded by these negative messages. So, and I think that really leads to like the fear of judgment, right? Not wanting to disclose or, say, hey, I need some additional support here. And I know that this was particularly an issue, even more acute, I'd say, for people with developmental or intellectual disabilities who had greater interactions with, Children's Aid Society workers in Ontario and these sorts of things. And like that fear of being judged and having something taken away from them, often their children at the end of the day. So anyways, just a few key points there. And then in terms of the providers themselves, so this would be on the next slide, Elise. So this is what the healthcare and social services providers and decision makers said, that they feel they didn't have sort of adequate training learned on their own nor were there sort of the incentives to support working with disability communities and sort of adapting programs and services to their needs. And so on that, I think I will, unless you have anything else to add, Hilary. I know I covered that last point a little briefly, but if you, I'll pass it back to you for the next segment of our talk.
Wonderful, thanks. So as we've been kind of reflecting on the combined findings of both the population-based data as well as the qualitative data, another key component of our advisory committee involvement has been coming up with a set of recommendations. And I won't go into too much detail on these here, but you can see them on the slide. But really our regular meetings with our advisory committee, both as we presented the results of individual papers, as well as more now as we're kind of bringing everything together for a final report, it really has been key to have those individuals with lived experience and with clinical experience involved to really figure out what we should be saying to healthcare providers and administrators for what needs to change in the system. And it really relates to accessibility, accommodations, and kind of creating a more flexible and integrated service system with adequately trained healthcare providers who have better knowledge of disability. So next slide, please. One of the really neat things we've been able to do is to actually create some training resources for different groups. We worked with a group out of McMaster that trains public health nurses to create a resource on quality care essentials for them. These are the nurses that often do home visits with new moms. So thinking about how to make those home visits more accessible. Next slide. And one of the most exciting pieces, I think, was this winter we were invited by the Provincial Council for Maternal and Child Health to create a suite of resources that they have on their website and that have been delivered to healthcare providers and administrators across the country, actually, with resources for new parents or prospective parents, I should say, for healthcare providers and for healthcare administrators as well. And one of the things that we did through these resources was not only were Kate and Laurie involved as co-authors, but we also shared them with our advisory committee to make sure that they agreed on the messaging. And we also included quotes from our study participant for every recommendation that we made, so that you can actually see throughout that everything that's in these resources is made, you know, both with and based on the opinions of people with disabilities. Next slide, please. We've had a number of other dissemination activities, including a number of papers. Laurie and Kate and Leslie are doing a talk for CADITH coming up on the importance of inclusion of disability in research and healthcare. Laurie also led a policy piece in talking about the importance of inclusive health research for healthy debate. So we tried to take lots of opportunities to work together as a team, both as academics and as community members, to make sure that we got our results out to as many different stakeholders as possible. Next slide, please. And so now we're going to talk a little bit about lessons learned, some of the challenges we've experienced, and also recommendations for future research. So starting with lessons learned on the next slide. I'll reflect a little bit and then I'll turn it back to Laurie to finish off. And I know we only have 10 minutes left, so we'll try to go through this fairly quickly, but I think these are important learning points. One of the things I really learned through this as an epidemiologist was that you know, from a community perspective, numbers can unintentionally be used to stigmatize and medicalize. If you think of some of the disparities that we found in our ICS data, there was a fear among our advisory committee members of how the information would be used and how it would be interpreted. And so we've really tried to learn and create ways to make sure that our findings call for changes in medical care and to make sure that they're framed in a way that makes improvements rather than medicalizing or stigmatizing people's experiences. As you saw from some of the examples I gave, language matters, and I gave these examples in relation to some of our ICS findings, and we've really learned a lot about framing things in acceptable ways as we've gone through this. We've also learned a lot about engagement and how we really want to make sure that our engagement with community members is meaningful, and also that it's recognized in tangible ways, and not just participation, but also co-leadership. And so I think we had some success in that area for sure, in terms of Kate and Laurie being able to be co-authors on papers and presentations, but also to lead some of those things themselves, including the Healthy Debate article that Laurie led. One of the pieces that we're also learning is the importance of an intersectional approach. And I think that's something that we can do better going forward, especially recognizing the intersections of ableism and racism. So that's something that we're working on as we learn. Next slide, please. We also experienced some process challenges. So from a really practical point of view, as when I wrote the grant, I budgeted for a certain number of advisory committee members, and our advisory committee membership grew as the needs of the project grew, and we met more people and expanded our network. And so, as I've written grants since then, I've budgeted more to be able to expand that as the needs of the community are identified. We also struggled a little bit with a true partnered approach for the ICS component, as I've mentioned throughout. There are, of course, many structural barriers in academia in terms of supporting this kind of work. And we've learned also about the need for supporting the peer researchers through very emotional, often interviews, as we've done this important work on a very sensitive topic. And of course, this means needing to have time to build relationships and build trust. Next slide, please. So I'll just briefly mention some recommendations. I think with all of this partnered work, we want to be able to start early and think longitudinally in terms of building relationships that last. We need that flexibility in grant budgeting, pushing back sometimes against traditional academic structures that don't necessarily support this kind of partnered approach, and also just making sure that we're really responsive to our community's input and the ways that we work together. And with that, I'll turn it back to Laurie to add her recommendations.
Great. Yeah, so in terms of my lessons, I guess they're more perhaps personal in nature in terms of some of the lessons I learned, and also some recommendations perhaps for you, not necessarily based on this project, but just overall, if you're involving people with disabilities or patient partners, right? As the term is sort of used differently, but I think a lot of those same ideas apply. But one thing that I experienced over the last number of years, because it's been like 3 years at this point that we've been working together, is some of the internalized sort of ableist attitudes that even I held. I think when it's perhaps because I was diagnosed so young, but I powered through, so to speak, a lot of those barriers in healthcare and life. I sort of hid my disability for years, worried about that. And I guess I just had the time to self-reflect on this to realize that, right? Sort of come to that personal realization. And I mean, I learned to adapt to things over time. I often say that's sort of like the strength of people with disabilities, but sometimes for me personally, that hasn't always been a good thing, right? Sometimes being too adaptable mean I didn't challenge, some of my healthcare providers. My doctors didn't talk to each other. I'll just do it, right? Because I'm just like trying to find a solution, but it still doesn't, really it's the system around me that should be changing, and I shouldn't have to bear so much responsibility. I know a lot of people with chronic illness say it's like a full-time job, right? Managing the different elements. And I mean, that's sort of telling. So yeah, I guess it's just allowed me the time to reflect about some of those things that I'd experienced, and now has changed sort of my perspectives looking out on, for example, our world post-COVID, right? And what are we doing to support people with disabilities or those with chronic illnesses? I also learned to be sort of more inclusive, to explicitly include people. For example, something that Kate, and I guess I've learned a lot from Kate as well, right, as a co-peer researcher, but to specifically include people who identify as It's not just women that are people who identify as women that can be pregnant. And we learn to use language that explicitly includes gender diverse people that can be pregnant, because if they don't see themselves, for example, even in the recruitment notices and that, I mean, they're not going to come and talk to us, right? And we don't want that. We want to know what they're also going through. And as much as I worked with like an excellent team, it was hard to hear the experiences of other people with disabilities. Like when I did the interviews, many went through as much as I did or more. Some of them lost children, and I had to hear both. I seem to always get the situations where they had such sad circumstances. And many experienced the same helplessness I did. So I relived, I think the interviews in particular were challenging for me. And it's really why we changed. So I was, testing out our interview guide at one point. And it's why we instituted, because I found even resharing my story with like people I trust, and that was so difficult. Again, even though so much time had elapsed, right? The memories are still very fresh. So it's why we instituted like a mandatory follow-up with participants. So if they did feel that, but yeah, it's difficult, right? And I'm also like, not just this experience, but being more selective in like how I share my these very vulnerable situations in life with others. I also feel like part of the disability community more formally now. My experiences were sadly not unique, but I also did realize my own privilege as someone with a higher education level, higher health literacy, as I interacted with the system, and that I advocated for myself, but not everyone was able to. So I guess I realized some of those protections as well that I had. So those are my own personal lessons, I guess. But in terms of recommendations going forward, and I noted just a few papers here that I've been involved in, and I'd really recommend you to self-reflect. And in our first paper there, it's actually just a preprint now, but it's undergoing peer review. There's actually a specific section there about considering unconscious bias. And because I think this work with communities really, before you engage throughout the engagement, it really does require a lot of self-reflection and to consider any unconscious bias that you may have working with stakeholders or working with patient partners. And so I'd highly recommend reading that. You can find it on the Open Science Framework. It's more just to get people thinking, and it's not meant to criticize, right? It's just meant to say these are people's experiences, and here are some things that you can consider going forward, right? And to make sure that people feel validated, that they feel their lived experiences are worth just as much. And I think really the other points kind of support that, right? If you go in sort of with the right mindset and the right attitude about things, that you can create the right environment, setting the right tone for authentic engagement, as Hilary mentioned, right? Making sure that you're listening to people, right? Because it can have an impact on them, whether you like it or not, right? Because often they're reliving or feeling further marginalized based on their own healthcare experiences. And this also means, building capacity, providing compensation. And again, you'll see a link to a paper there, which gives some solutions for trying to navigate some of those institutional barriers, as well as being flexible in your approach in terms of those terms of reference, like used by Hilary for this project, that it's not necessarily a one-size-fits-all approach, that people do different things. Like Kate and I did different things because we have different strengths. And to just ensure you listen and acknowledge and lean into the discomfort, regardless of how uncomfortable it is. Just, try to go into it with an open attitude, and it's okay to feel a little uncomfortable, and you could feel uncomfortable together. So on that note, I'll close it off. I know we're short on time here, but really just hope that this is a good example of the moral and ethical responsibility to meaningfully engage people with lived experience in the research process. I put the quote, "Nothing about us without us," which has long been sort of associated with the disability community, but I think it actually has its roots elsewhere. But nonetheless, it's important because really it's that principle of not doing anything to us, but with us. And I think that sort of approach can have have positive benefits, not just to the communities themselves, but to the research process and the creation of research evidence. So last slide is really just our contact info, and thanks so much for having us here.
Thank you so much, Laurie and Hilary. I do see that we've run a little bit short on time here, but really appreciate the depth of insights and the candidness with which you shared your stories. And I think each one of your recommendation points deserves a 60-minute talk on its own, because there's really a lot to unpack there. Just in the interest of respecting your time and other folks, perhaps what I'll do is I can still paste the little Menti that we were going to use to gather anonymous questions in the chat. And if folks want to tack some questions in there, our team will do our best to get some answers to those questions to you, whether that be, oh, what's this? I don't think this is the right poll, end poll. But we'll do our best to get those answers to you, whether it be in a written format sent out with the recording, or perhaps open questions to discuss in future sessions. But thank you again so much to our presenters, and thanks everyone for attending. I'll put that link in the chat right now.
Thank you both.
Sorry we talked so much, we didn't have enough time for discussion, but we really appreciate everyone being here.
I really appreciate your personal reflections and lessons. It's so important, and I look forward to reading the follow-up papers as well. Thanks again.